Hi, everyone. My name's Jessica Harding. I'm an assistant professor, and I'm located in the Department of Surgery and Medicine, but I have a joint appointment in the Department of Epidemiology and collaborate quite closely with the Georgia Center for Diabetes Translation Research. And I'm really glad to be presenting to you today to talk about some new research that I've been working in the space of diabetes and COVID-19. And just for context, for those of you who may have joined or chosen to watch this recorded version, it's pretty small attendance for the actual talk today. So I'm going to keep it pretty informal and hopefully interact with some of the people that are on the call. But if you have any sort of other questions or input after you've watched the recorded version of this talk, I'd love to hear from you. But I just want to give some important context to the broader diabetes group for those of you who haven't met me yet, just give some context as to how I got to this space of diabetes and COVID. And so I did a PhD back in Melbourne, Australia, and I finished that in 2016. And that PhD was really looking at whether or not people with diabetes have an excess risk for cancer compared to people without diabetes. And upon finishing that PhD, I took up a post-doctoral fellowship at the CDC under the supervision of Dr. Edward Gregg, which maybe several of you know, and really immersed myself in the space of looking at more broadly diabetes complications in people with diabetes. And what we're sort of finding in that space was that as people with diabetes live longer, largely because we've got better at treating a lot of complications from diabetes, and certainly a lot better at treating cardiovascular complications of diabetes, people are living longer and dying less. And so there's sort of this diverse range of complications, what we kind of are considering emerging complications that we're seeing are in excess risk among people with diabetes. So that's things like cancer, some infections that we didn't know were previously associated with diabetes, some cognitive decline. And so the next sort of piece of that puzzle, for me at least, is to look at this newest public health crisis that we have of COVID-19, where we are seeing that this excess risk or the risk looks different for people with diabetes compared without. And so this is sort of a new complication that we're adding to the array of things that people with diabetes are experiencing. And I probably don't need to tell anyone here that people with diabetes are more likely to have severe complications from COVID-19, so things like hospitalization and mortality. But there's a whole host of other things in that space that we're starting to learn. And I kind of want to focus this talk on those three things. So this talk's going to have sort of three parts. The first is I want to summarize the existing evidence around whether or not diabetes is a risk factor for long COVID, whether COVID itself actually induces new onset diabetes in people who previously did not or were not diagnosed with diabetes. And then the third piece of this talk is pivoting a little to look at how the COVID pandemic more broadly disrupted care for people with diabetes in the last few years. And I think a good starting place for this is to really talk about what is long COVID before we can answer the question of whether or not diabetes is a risk factor for it. And I don't think I'm going to give you a satisfactory answer for what is long COVID, but we can certainly look at what we know so far. And the interesting thing about the emerging evidence of long COVID is that there was an opinion piece published in the New York Times by Fiona Lowenstein in about April of 2020. And she reported the first kind of idea of these lingering symptoms of COVID-19. So this is what we sort of consider the index report or case of long COVID. And I think considering health research or medical research in the age of social media, this is really interesting because this index case, if you will, kind of led to a really impressive patient-led research collaborative where a lot of patients who had been diagnosed with COVID were getting together and they started cataloging the breadth of symptoms that they were experiencing post-COVID-19. So it sort of served as a stepping stone for a gateway to more rigorous research that was going to be conducted. And in 2021, this meta-analysis came out in Scientific Reports to look at, the prevalence of these symptoms that were being reported among people who'd been diagnosed with COVID-19. And what you can see here is that the most prevalent symptom appears to be fatigue. So 58% of patients were reporting fatigue, followed by things like headache, loss of smell or taste, memory loss and brain fog, which perhaps you've all anecdotally heard of this, but other things like chest pain and joint pain was also being reported in a large proportion of patients. And I think what you can at least take away from this figure is that long COVID doesn't really appear to be one thing, nor does it affect just one system. And I think the current definition from the NIH and the CDC reflects that we don't really know what long COVID is. And the definition currently is that long COVID is sequelae that extend beyond the 4 weeks after initial infection of COVID-19. And the terms long hauler and also the post-acute sequelae of COVID-19 are used interchangeably with long COVID, and I might do that throughout the talk. So how common is long COVID? And I think this is a strong matter of debate. There's several different studies which report quite significantly varying estimates. One of which was from this meta-analysis that was published in JAMA Network Open last year, where each dot in this figure is representing an individual study from the country that's listed underneath it. And what you can see on the y-axis is the percentage of COVID patients who were reporting PASC symptoms, at least 4 weeks following infection. And on the x-axis is the follow-up time from the COVID infection in days. And what you can see is that these point estimates are kind of all over the map. They range, from reporting a prevalence of PASC in around, the 15%, all the way up to maybe like 80 or 90% in some other studies. Most of these studies are small, usually with about a couple of hundred patients, and the size of the study is reflected by the size of the dot. There was one big US study, which you can see in the middle of that figure, that reported using electronic medical record data, the incidence of PASC in more than 250,000 patients. And they showed that at 90 days, the frequency of these symptoms being reported was about 35%. But the specific this was based on ICD codes and specifically focused on neurological or psychiatric diagnoses. But a lot of the early work that was done in the space of long COVID didn't really have appropriate comparison populations. So we didn't really know whether these ongoing symptoms were unique to long COVID, or whether this is the sort of thing we would expect with someone was to get another acute upper respiratory tract infection. So one of the first studies to rigorously assess whether long COVID is unique using appropriate controls was this study by Ziad Ali and colleagues using VA data on more than 70,000 veterans earlier on in the pandemic. And they compared the risk of several different long-term sequelae relative to several different control groups and followed these individuals for 6 months. And so this figure is maybe a little difficult to see, but I'll walk you through it. On the left-hand column are all of the different body systems that were investigated, and next to that is sort of the individual complications that were looked at. And what they're reporting in sort of the left column of results is the adjusted hazards ratio, comparing, in this figure, individuals who were diagnosed with COVID compared to the general VA population. And in the right column of results, we're looking at excess burden. And the different colors represent the severity of the COVID infection. So it's people who were either diagnosed with COVID-19 or hospitalized with COVID-19 or admitted to the ICU. Broadly, the takeaway from this is that across all of these different systems and for all of these different diagnoses, diagnosed at least 4 weeks out from COVID-19, is that there seems to be an excess risk for having these new diagnoses in people with COVID compared to the general VA population. And so, the second take home from this is that as the severity of the infection increased, the risk of these long-term complications also increased, which for those epidemiologists in the room, that's kind of one of those Bradford-Hill criteria for establishing causation, that if the exposure increases and then the outcome increases, then that's evidence at least of a dose-response relationship. But this data, or this particular analysis in the study, didn't compare to other infectious diseases or other respiratory infection diseases specifically. So again, we're still kind of left with this question, well, is long COVID different to something like influenza? And in this study, I missed a bit. I want to tell you this bit first before I move on to talking about influenza. The other thing that this study was one of the first to show is that in people with COVID compared to the general population, the incidence of new diabetes diagnosis appears to be increased, and it increases with increasing severity. And I just want to flag that because that's an important segue for the second part of my talk. But back to talking about whether COVID is different to something like influenza. And this is the same data that you're looking at as compared with the earlier slide, where we're looking at hazards ratios and excess burden across all of these different systems. And broadly, what you can see is that people with COVID compared to people who had historical influenza, so this was specifically a 2019 cohort that they compared to make sure there was no potential misclassification of COVID-19. And you see that there is an excess risk in this patients compared to influenza. And the authors conclude that the magnitude of risk of these complications appears to be higher in COVID. The breadth of organ involvement is greater, and it appears to be a different kind of post-viral syndrome than what you would see in something like influenza. So who is at risk for long COVID? There was another study published in Nature Communications by the same group, and again, using VA data. And here this figure is looking at the proportion of people reporting these various symptoms on the left-hand column, at least 30 days post-infection. So this figure, again, is really busy, but the take home here is that as the color increases, the proportion of people experiencing that symptom increases. And each column represents a different subgroup of the population. So they looked at this by different age group, by gender, by race. And also in those far three right columns, they're looking at the proportion of symptoms being reported among people with no comorbidities, with 1 to 3 comorbidities, and then among people who had at least 3 or more comorbidities. And what you can see here is that there are there's not really a clear pattern here. There seems to be differences in reporting of PASC by gender, by race, by age, and also by baseline health line status. So this doesn't appear to be a monolithic entity, and it doesn't behave the same way across different groups. This study didn't look at whether or not diabetes alone was a risk factor for long COVID, but at the end of January of this year, this piece came out in the New York Times and grabbed my attention, which was reporting on the findings of this study published in Cell of January of this year. And this was a multi-omic study that identified 4 significant risk factors for developing long COVID, and one of which was diabetes, and what appeared in that New York Times article. So this was a really complex study that used several different methodologies, proteomics, metabolomics, but they also had some EMR data and survey data among 206 patients. And they looked at symptoms at 2 to 3 months post a COVID infection, which was collected through various questionnaires and validated against the EMR data. And they correlated those symptoms with pre-existing conditions like diabetes. And diabetes consistently showed to have the strongest correlations with the most amount of symptoms. But as far as, sort of rigorous epidemiological designs go, this study wasn't the strength of this study. The strength of this study was the metabolomics and proteomics components. But it got me thinking, are there other studies that are reporting whether or not diabetes is also a risk factor for COVID-19? And so in collaboration with several of the other people in this group, including Shivani Patel and Mo Ali, we conducted a systematic review to examine 2 different research questions. The first was to identify whether or not diabetes was a risk factor for long COVID, but also to see whether diabetes itself was a manifestation of long COVID, or in other words, were people with COVID developing new onset diabetes? Because around this time, there were studies coming out to say that, post-pandemic, or what we're calling this post-pandemic period, there seemed to be an increase in the incidence of diabetes. But most of these studies were only looking at, sort of across time. Not many of the studies were looking specifically in people who'd been infected with COVID, which is necessary to identify whether COVID itself is the precipitating cause of new onset diabetes. And I'll just say really briefly that this work was presented at this year's ADA meeting in New Orleans for any of you who are able to attend. And it received a lot of media attention, I think, just because it had the word long COVID in the talk. And we've just had it provisionally accepted into diabetes research and clinical practice just last week. So I'm just going to outline the methods of this research, this review, and summarize some of the results. And then, we can certainly pause to ask any questions if there are some. So the search strategy, this was registered with Prospera, and we used PubMed and Embase through August, and used the keywords diabetes and COVID-19. We decided, we included studies that were published in English, and studies that reported on either the incidence of long COVID in people with versus without diabetes, or the incidence of new onset diabetes in people with versus without COVID. And these all had to have a minimum of 4 weeks follow-up after COVID. We extracted data on study characteristics, population characteristics, and also the findings in rate ratios or odds ratios. Our analysis, we did not conduct a meta-analysis for this because, as I'm going to show you, these results were far too heterogeneous to pool in any reasonable manner in a meta-analysis. So we've simply narratively synthesized these results and also reported the quality of studies using a modified Newcastle-Ottawa scale. I also want to make a plug here for my MPH student, Sophia Oviedo, who was the person who helped me do all of this work and screen all of these different studies to meet our eligibility criteria. So to summarize this first aim, or summarize the studies that were included in this first aim, we had just over 4,800 records screened, of which 18 met the inclusion criteria for this aim. Most of the studies were from high-income countries, but we did have studies from India, Ghana, Turkey, and Bangladesh. The follow-up time ranged from 4 weeks to 15 months, and the sample size ranged from 104 to over 800,000 people. Among the studies, 33% of the studies were done among a hospitalized population, 44% were done among a non-hospitalized population of patients with COVID-19, and the rest were kind of a mix of the two. For all of the studies, diabetes was ascertained using ICD codes in electronic medical record data, and there was significant heterogeneity in the way PASC was defined, which I guess is unsurprising given the definition that I've previously given you of what long COVID looks like. And so it ranged from things like whether or not patients were simply reporting fatigue or some other ongoing symptoms to definitive diagnosis codes of whether or not you had an incident myocardial infarction or something like that. Just one study reported on type 1 and type 2 diabetes separately. All of the others just did a combined exposure of diabetes. And all of these studies were among adults, though, of course, that was not part of our inclusion or exclusion criteria. And the majority of studies were deemed to be of moderate or high quality. And so the drum roll for this particular research question is that 8 studies, or 44% of the studies we identified, suggested that diabetes was a risk factor for long COVID, but 56% of the studies showed a null association between diabetes and long COVID. For the studies that did report a positive association, the relative risk ranged from 1.3 to 4.4, and about 40% of studies showed that the relative risk was greater than 4, indicating a really strong association between diabetes and long COVID. So our second aim, if you remember, was to decide whether or not COVID increases the risk of new onset diabetes compared to people without COVID. And for this particular aim of the review, we found 10 studies. Most of these were from the US or the UK, and we had just one study that was multi-country. 40% of the studies reported the incidence of total diabetes, 30% reported the incidence of type 2, and 30% reported type 1. The incidence of diabetes was ascertained using ICD codes for all of these studies, except one study that also used fasting plasma glucose. And the follow-up time ranged from 30 to 457 days. And the sample size for this was much bigger. It was from about 280,000 to over 9 million people in the biggest study. 3 studies did include data on children, and 90% of these studies were considered to be high quality. And so the overall conclusion of this study was that 90% of the studies we identified suggested that COVID-19, compared to people who did not have COVID-19, had an increased risk of developing new onset diabetes in people who were previously not diagnosed with diabetes. These relative risks ranged from 1.10 to 3.76. But there are some nuances that I think are important to mention. So the risk varied depending on what the comparison population was. So as you can imagine, the greatest risk estimates were when the comparison population was people without COVID or the general population. But when the comparison population was people who had another acute upper respiratory tract infection, then the risk estimates were lower. the risk also varied by hospitalization status. So generally speaking, as the severity of COVID-19 increased, so that's whether or not you were hospitalized or ended up in the ICU, the risk of new onset diabetes also increased, but that actually wasn't true across all studies. And finally, and I think a really important caveat to this work, is that the risk of new onset diabetes decreased with increasing time from COVID infection. So there was just 2 studies that did this sort of time varying analysis, if you will. And for example, one of them showed that at 4 to 12 weeks post COVID infection, there was a significant increased risk for new onset diabetes, but this decreased to a null association when you got to 13 weeks post infection. So the mechanisms that are underpinning this bidirectional association are not entirely clear. So this figure comes from a nice paper that was published in Lancet Endo a bit earlier in the pandemic. And this figure was generated largely to try and explain why people with diabetes were more likely to have severe COVID compared to people without diabetes. But it is thought that these same mechanisms are also likely to explain the risk for long COVID and also possibly new onset diabetes. So the primary hypothesis is that SARS-CoV-2 has an affinity for binding to ACE2 receptors that are expressed on islet beta cells. And this is thought to, in turn, impair the production and secretion of insulin, which worsens hypoglycemia and can lead to things like ketoacidosis. But there are other possible explanations, including autonomic dysfunction, a hyperactivated immune response, persistent low-grade inflammation, which could lead to insulin resistance. But something that appears to be missing from this figure, at least, is that it's also possible that people with COVID-19 who have diabetes have been differentially exposed to some of the social determinants of health, particularly during the pandemic. So these can be things like the pandemic lockdowns, different job loss, income loss that might have been that might have indirectly contributed to this increased risk for people with diabetes. And for the case of new onset diabetes, I also think another mechanism that is worth considering is that the detection of new onset diabetes could simply just be this idea of detection bias, that we're previously picking up undiagnosed cases of diabetes simply by virtue of having a new diagnosis of COVID-19 means that you're now interacting with the healthcare system perhaps more than you would have been had you not have had that COVID-19 diagnosis. And certainly, we see that when we look at these studies that are stratifying by different time. And also, when you look at severity as well, so looking at people who were hospitalized compared to people without, there seems to be an increased risk. But of course, hospitalized patients are also interacting with the healthcare system more, and there's just plenty more opportunity for a previously undiagnosed case to be picked up. So we need a lot more research, I think, to answer both of these important questions. The good news is that there are current and ongoing investigations that are aimed to do that more broadly, but I think we can, within these resources, look specifically at diabetes. And one of those that I just want to flag briefly is this Recover study, which is an NIH-funded initiative that's involving lots of different sites from around the country. And here at Emory, we're fortunate enough to be one of the participating sites. This is led by Professor Rachel Patzer and Igor Offertoken, and they lead an Atlanta-based initiative that includes Emory, the VA, Hope Clinic, and also Kaiser Permanente, Georgia, to actively recruit participants into this sort of second component that you can see here on the figure, which is recruiting patients for these cohort studies where we intend to capture a lot of data via questionnaires, some capturing blood information, and follow these individuals for up to 3 to 4 years to look at the long-term implications of COVID-19 compared to appropriate controls. But the breadth of recovery is huge. There's also opportunities for clinical trials to look at different therapeutic domains for addressing COVID-19, a really strong biorepository core to try and really get at the pathophysiological mechanisms for how COVID-19 is affecting health long-term. And I also want to make a plug for another research project that was recently funded by the NIDDK. And this was a grant led by this group, and specifically Shivani Patel and Venkat was also involved. And here we're leveraging our relationships with Kaiser Permanente to look at the incidence of new onset diabetes across these 3 distinct geographical sites. So specifically, we're using Kaiser Permanente data from Georgia, from Hawaii, and from Northwest, where we'll have at least 3 years of follow-up. And we intend to look specifically at new onset diabetes in 3 distinct groups across the life course. So this is children, pregnant women, and also adults. And we have several analytical plans proposed to look at multiple comparison groups, so comparing to historical cohorts, to people with influenza, analyzing these relationships over time to try and tease out this idea of detection bias as well, and several important subgroup analyses by race and gender, by COVID wave, by whether or not you were vaccinated, and by BMI, which has also been flagged as a really important component of the COVID story. And so why should we care specifically about this relationship between diabetes and COVID-19? Well, firstly, long COVID does not appear to be rare. It's a multifaceted disease that affects multiple organs, and it's happening against a backdrop of a known rise of diabetes cases in the US. So at the moment, there are conservative estimates that suggest that about 4 to 7% of people will develop long COVID. But even a 4 to 7% proportion of people will result in high absolute numbers, given the backdrop of people that are being infected with COVID and who are likely to cyclically be infected with COVID for the long-term future. And this is going to have implications for life expectancy. That's going to take us a long time before we see the impacts of that. But it also is going to have impacts on development and education attainment, specifically as we think about the impacts that long COVID has on brain fog and cognitive function. It'll have important economic and social implications. And so I do think that we need to be thinking about the implications of long COVID, and I think governments and health systems are starting to do that. So they're starting to develop post-COVID clinics across the country. Vaccination and preventing the spread of misinformation around vaccination is also going to be key to preventing initial infection of COVID-19. But I think that the research that I've presented today suggests that, at least for people with diabetes, it might be important to be making sure that we're monitoring glucose continually, because ensuring that is maintained within normal range might have important benefits for preventing long COVID. And as I've mentioned, we certainly do need more rigorous research with longer follow-up, which hopefully is coming. So I think I'll just pause there before I move on to the next part of the talk and just see if there's any questions. Okay, I'll keep moving on. So I'm pivoting a little bit for this third part of the talk to look at how diabetes care was disrupted during the pandemic. And this is original research that I have been doing in collaboration with Kaiser Permanente, Georgia, and which was funded by a GCDTR pilot grant. So I'd like to acknowledge that funding source and thank this group for the opportunity to do this kind of research, and hope that it'll lead to bigger things. So as quick background, there was a study that was published from the UK just a few months ago that looked at the 8 diabetes care processes in a national diabetes audit in England, and looked at whether or not people were meeting these care processes in the pandemic period compared with the pre-pandemic period. And what you can see from this graph is that all 8 care processes, so the proportion of people meeting all of these guidelines, which is an annual check for these 8 things listed, declined by 50% in 2020 to 21 compared with the 2019 to 2020 period. And this is significantly different to changes that we've seen in pre-pandemic years. So if you compare 2018 to 2017, you can see that there might be slight declines in people achieving these guidelines, but it's pretty small. And it's certainly not as consistent as what we're seeing for comparing with the pandemic period. And so the project that I have been leading was to do this sort of work in a US-based study. And the idea here is to compare diabetes care, the care patterns pre and post the COVID pandemic. And to do this, we're leveraging the Kaiser Permanente Georgia data infrastructure. And we identified all individuals who had prevalent diabetes as of January 1st, 2018, and also who had continuous enrollment right through to the end of 2021. And this was about 24,000 individuals. And diabetes was defined using looking at historical EMR records and identifying anyone who'd had a diagnosis of diabetes or an HbA1c or fasting plasma glucose levels in the diabetes range, or who had a prescription for an anti-hypoglycemic medication. And we were able to look at 7 different annual diabetes care processes. So these are whether or not people were doing this in both years of the specified period. So the pre-diabetes period was considered 2018 to 2019. And so we looked at people, whether they'd had blood pressure measured in both of those years, and then compared that to the post-pandemic period to see whether or not people had had blood pressure measured in both of the post-pandemic years as well. And we did a regression analysis, and this was adjusted for age only, because this was a continuous or a closed cohort study, if you will. So it's the same individuals who are in the pre-pandemic period to the post-pandemic period. And so really the only thing that changed, or the only thing that we were able to measure that changed over that time period, was age. So looking at these study characteristics briefly, you can see that in 2018, the average age of our participants was 60 years of age. 56% were women, 56% were Black. 5% of people indicated that English was not their primary language spoken at home. Median household income was about $70,000. 13.5% of patients had a previous diagnosis of COVID-19. And to get a sense of healthcare access, if you will, 46% of patients had their flu shot done in 2019. And just looking at some individual comorbidities, we can see that about 20% of patients have some level of kidney disease, 14% have congestive heart failure, 14% have liver disease, 27% have peripheral vascular disease, and about 37% of them have chronic lung disease. So our first result is looking at the pre-pandemic period. So in 2018 to 2019, for each of these individual diabetes care processes, what proportion of participants did not have this measured in either years, had them measured in one but not the other, and had them measured in both years. And you can see that certainly for HbA1c and blood pressure, a very large proportion of KP members are achieving these recommended guidelines of having an annual check for these things. Certainly for things like eye and foot exams, the proportion of people meeting these guidelines is pretty low, even in the pre-pandemic period. And if we compare this to the post-pandemic period, it's a little maybe hard to see, even though they're sort of next to each other. Broadly, what you can see is that the proportion of people who are meeting guidelines, which guidelines is technically 2, but I think it's important to see if 1 annual measurement is changing too, that the proportion meeting these 2 annual process measurements has declined during the pre and post-pandemic periods. And if we want to look at what that looks like side by side, you can see that for HbA1c, there was an absolute change of about 6% in the pre to the post-pandemic period, about a 13% decline for blood pressure, 9.6% for cholesterol, about a 5% decline among the proportion of people meeting annual guidelines for creatinine and urine albumin creatinine ratio. But also, even though the numbers are small here, there's still been these substantial relative declines in the proportion of people meeting guidelines for eye and foot exams. And this is looking at the same data, but just presented a different way. So what proportion of people are meeting no annual measurements compared to, say, 7? And what you can see is that the proportion who are sort of only meeting 0, 1, or 2 of these guidelines increased during the post-pandemic period, but the proportion of people who are meeting 4, 5, 6, or even 7 of these guidelines per year has decreased significantly in the post-pandemic period. And when you plug this into a logistic regression analysis, what you can see is that there have been significant declines in the likelihood of KP members meeting each of these annual care processes in the post compared to the pre-pandemic period. And the greatest declines were seen for blood pressure. So if you're looking at this odds ratio for blood pressure, what this says is that in the post-pandemic period, KP members were 72% less likely to be meeting these care guidelines compared with the pre-pandemic period. And this is also kind of high for foot exam and maybe eye exam, which is perhaps not surprising given that these are the things that require perhaps the most in-person contact. So the conclusions of this study to date are that diabetes care was significantly impacted by the COVID pandemic in this insured population in the Southeast, and that the greatest declines were seen in annual measurements of blood pressure followed by these foot and eye exams. There's some important study limitations that I do want to mention, and perhaps we can discuss during question time, is that this is an insured population, so the results of this study are not so generalizable to an uninsured population. And we also required continuous enrollment so that we could examine the impact of the pandemic specifically and not other changes in the individual construction of, say, in cross-sectional surveys. But there are limitations to that approach, I think. You might have noted specifically that the proportion of people meeting annual foot surveillance guidelines was pretty low. And I have concerns about the way we've captured that with procedure codes in the data set. So I think it's an underestimate of how many people are meeting these guidelines, but regardless, I think we're still able to look at the relative change in that between the pre and post-pandemic periods. This data set doesn't have incident comorbidity data, including BMI. And of course, these diabetes care processes are intermediate outcomes only, and we need longer follow-up to see whether or not these diabetes care processes are impacting, HbA1c management, as well as things like increased risk for complications and mortality. So I have several next steps for this work, and it's certainly in its infancy. And again, I welcome any comments or suggestions on what I've presented so far. But some of the next steps we have are to stratify these results by some important subgroups such as age, race, and gender to identify any disparities among these groups. My MPH student, Sophia Oviedo, also as part of her MPH thesis, is going to specifically examine the impact of access to telehealth in the ability to meet these care process guidelines. And for anyone who happens to be going to the IDF in Portugal in December, I'll be presenting some of this work at the meeting. I'll be presenting something slightly different, looking at HbA1 specifically in the pre and post-pandemic periods in men and women. But I'll also be presenting some of this work at the International Diabetes Epidemiology Group meeting, which is also happening in Portugal just prior to the IDF meeting. And as a member of the IDEG group, I wanted to just take a moment to give it a small plug. So for anyone who is attending the IDF and would like to tack on a few extra days, this is a really wonderful meeting if you've not had a chance to attend. It's small enough that the networking opportunities are really great. We tend to have a dinner on the Saturday night, which is really fun. But you'll also hear from experts in the field of diabetes epidemiology and some of the latest research. And finally, there is we do a training day or a workshop on the first day of this meeting, and really encourage people from low income and middle income countries to attend this. Finally, I'd like to thank all of the collaborators that have been involved in these different research projects, as well as the sources of funding, and in particular, the GCDTR Pilot Award. And for anyone who is online, I'd be happy to take any of your questions.
Jess, this was terrific. Can you hear me okay?
I can hear you, yes.
Okay, awesome. So really, really awesome. Just a comment and then a question. The comment, anecdotally at least, I feel like the natural experiment of COVID and all of its impacts, everything from lockdown to vaccination, vaccination hesitancy, all of it, I think probably has an impact on rates, if you will.
Mm-hmm.
The reason I say that is mainly anecdotal in that in my patient population, the pre-vaccination era, I feel I saw a lot more people coming to say, I have these weird symptoms than I do now, for example. After the middle of 2021, I've rarely had people coming in and complaining of that. Well, maybe end of 2021. If they got 2 doses or something. And then the second item here is more of a question, and that's sort of going back to your first analyses and some of the literature around sort of the incidence of diabetes as it relates to people who've had COVID. The one thing I wanted to ask your comments and reflections on is type 1 diabetes, because if you think a little bit about how to distinguish between what was an effect, for example, of being in lockdown and consuming a lot of calories and not burning them, or people who were quote unquote predestined to develop type 2, how what do you think about the data with regard to type 1, and does that tell us a bit more in terms of causal inference, in terms of potentially that there's a causal link between COVID and diabetes?
Yeah, thanks for your comments and questions, Mo. I mean, I think the first thing that I'll say is you're talking about you have less patients who are kind of complaining about long COVID. Is that what when you're talking about, they're talking about symptoms like long COVID, right? Yeah. So
yeah, long COVID, yeah.
Yeah. So, I mean, I think a way to kind of see whether that's true or just anecdotal, I think, is to, and this is what we're going to plan to do in this grant with Shivani and Venkat, is to look at different COVID waves as well over time, and to also explore this in people who are vaccinated and non-vaccinated. And maybe this was something that was really poignant at the start of the pandemic with a particular strain of COVID-19 and among people who were vaccinated. Maybe it's not a big deal anymore. But I think really teasing it out with some of that kind of data is going to be really key to answering that question. But I have, in conversations that I've had with people about long COVID, I think everyone got really excited about it. Well, not excited, but excited about this potential research opportunity for this and to investigate this serious condition among this population. But, the other 50% of people that I spoke to really said, I think we're making maybe a mountain out of a molehill in this particular situation. So, I mean, I think the jury is certainly not out on that one yet. I think we need to do some more rigorous research. And then to answer your question around type 1 and type 2 new onset diabetes, I mean, I completely agree with you. You could maybe argue that because of all of the disruptions that the COVID pandemic brought about, maybe the incidence of type 2 diabetes, maybe it's increasing as a consequence of the broader COVID pandemic as opposed to infection of COVID specifically. But I don't know that you'd make that same argument for type 1 diabetes, which is less influenced by these sort of social determinants of health, if you will. What I can say of the evidence that exists is that, not a lot of studies are looking at type 1 and type 2 diabetes individually. Or separately, and very few of them have biomarker data to really know whether we are looking at type 1 or type 2 diabetes. I think you're familiar with a study that was published out of the CDC that showed that type 1 diabetes was increasing in children. But I do think we need more studies that are showing that. Most studies are really just saying that the incidence increased post-pandemic compared to the pre-pandemic period, but it also may again have been due to delayed access to care because of lockdowns and in reductions in access to healthcare. So I don't think that we have an answer to that yet, but I agree with you completely that looking at type 1 and type 2 diabetes separately may be a really important piece of the puzzle to answer those questions.
Hi, this is Jean Walsh. Yeah, I have a question for you. A very interesting presentation. I really enjoyed it and learned a lot. I am curious to know, and you commented this as a limitation that you're, the studies that you're planning to do with the Kaiser data, and I'm really happy to know that you're going to be looking at kids because there's a lot of questions there. But who has Kaiser insurance? How does that group compare to others? Certainly income is going to be maybe higher than the average, but are there other factors that we know that make them, are they higher income in generally, just because of the insurance they have?
Yes. So looking at Kaiser Permanente data, the pro is that you have this kind of you have EMR data collected historically on this population, and it's really data rich, so that you can look at a lot of things. But you're absolutely right. It's not generalizable to the broader US population. I mean, it doesn't include people who are Medicaid or Medicare insured, which may be a large proportion of these people that are impacted by these things. But what I will say of the Kaiser Georgia data is that, yes, income is higher compared to the general Georgia population, but the proportion of the racial breakdown is pretty representative of the at least metro Atlanta area, which is where most of the Kaiser Permanente members are located, Atlanta and North Georgia. The breakdown by age and gender is also similar to the broader Georgia population. And even within the Kaiser Permanente data, we still see social gradients, and we see, so you can still kind of look at the relative differences between these different social strata, if you will, of course, with the caveat that it is missing a large, proportion of our population that doesn't have access to insurance. But the other thing I'll say is, when you have a group of people who have uniform access to healthcare, you can kind of take that away as one of the factors that might have decreased their access to care. So if they're all have equal access, at least by access to having insurance, then you can at least take that away as one of the reasons why they're not accessing care, and then trying to tease out some of the other nuanced factors that are reducing or changing why they're in receipt of these diabetes care processes, is really interesting.
Yeah, and it's interesting that you have both Metro and North Georgia, maybe to be able to look at some rural, urban differences.
Yeah. And so with the Kaiser Permanente data, we also have linked this to sort of like neighborhood level census tract data. So we can also sort of look at some geographic variation and some neighborhood level determinants as well, which I think is really interesting.
Great. I'll look forward to hearing more.
I don't see any questions specifically on the chat. So I think if there aren't any, I will just close this out for myself and thank those who were able to join for joining, and hope that those who have been able to watch this recorded version that you enjoyed it. And if you do have any questions, please reach out. My email is jessica.harding@emory.edu.